platforms and for future viewing. And we'll also send out the slides that are used today to everyone who registered for the webinar. Jackie, please turn on the recording. I think you already did because we all had to say got it. To start, we want to know who's here and where you're from, and we don't have time to do introductions, so please use the chat and take a minute to introduce yourself, your name, your organization, and what kind of work you do in this space. So we have 2 sessions today back to back. This is a 101, and then we're going to move into a 201. And some of you are registered for both. So we will end this session on time, if not a minute or 2 early, because those of us who are attending the second session, including me, are going to have to log into the second session. So brief background on the consortium for those of you who are new. We're also new, and we are a statewide effort aimed at advancing the integration of non-medical solutions into the healthcare delivery system so that we can improve health outcomes and reduce health disparities across the state. We think the consortium is both needed and timely. There's growing momentum across the state around the integration of NMDOH, as the state has decided to call it, into the healthcare delivery system. We're seeing health plans, providers, health systems invest in non-medical interventions on behalf of their patients. And in response, a growing number of community clinics and health professionals are implementing a variety of programs to improve the conditions that have a negative impact on the health of their patients that have nothing to do with medical care. The Texas Consortium is a dedicated space specifically for all stakeholders to come together to share and learn and support what is working as we build this field of practice around non-medical drivers of health. One program highlight for you, I want to tell you about our new offering on our website, which is driversofhealthtx.org. Last month, we launched a program index, and the program index catalogs NMDOH programs across the state that are sponsored by health system organizations, health plans, providers, hospital systems, clinics. And as far as we know, it is a unique offering. It's a single repository for all NMDOH programs across the state. And it features abstracts, short descriptions of the program, has searchable fields, including program sponsorship, drivers of health that you're interested in, target populations, health conditions, counties where programs are active, and evaluation status. And our goal is for this index to serve as a resource for everybody working in the field so that we can all know what's happening and who's doing what, and we can get in touch with each other and learn from each other. But the program index is only as robust as we all make it. So I'd like you to take a look at the index. And then if your healthcare organization is doing this kind of work, we want to include it in the index. Entering programs is easy. Jackie Klotz from our staff can walk you through it in real time. The link to the program index is in the chat along with Jackie's email. So please click on the link, bookmark it, and hang on to it, and get in touch with Jackie. So let me go on and introduce our session for today. Again, it's called Getting Started with Evaluation, Practical Examples from the Early Stages of the Measurement Journey. We'll have time at the end for Q&A, but feel free to put questions and comments into the chat throughout the presentation. We've got tech staff monitoring it, and we're going to do our very best to address every comment and question. At the end of the meeting, we'll also put back in the link to the program index and really want to encourage everybody to get your programs into the index. Now, I'm excited to introduce Dr. Leslie Wainwright, who will lead our discussion today. Leslie is the Chief Funding and Innovation Officer at the Parkland Center for Clinical Innovations. Her experiences range from academic research, pharma, biotech, as well as healthcare delivery. And today she's going to share her expertise on evaluating emerging clinical care delivery and NMDOH programs. Without further ado, Leslie, it's yours, and thank you so much.
All right. Can everyone hear me okay? Thumbs up? Yeah, very good. Well, Elena, thank you for that introduction, and for all of those who are joining us today. It's certainly great to have you part of our session. And as Jessica said, as much as we can virtually, this is a meeting amongst friends. We have a common passion and purpose. So we're just thrilled that you took some time out of your day to be with us today. What I'm going to do is part of a quick introduction before we get going with the panel is just do a little bit of a recap from the first session that we did with this broader group back in June. Between June to September, it has flown by. I lead, and my president and CEO, Steve Miff, leads the affinity group within the consortium that's specifically focused on impact measurement and evaluation. And through our steering committee and with some smaller group discussion we've had with others across the state who are focused on this very topic, we wanted to bring some grounding principles to all the work we do through the consortium. The first is we don't have all the answers. And so this begging for active participation is because this is truly a collaborative for how we work collectively to find our way forward. Second, we have this grounding belief that measurement is the first, not the last thing that needs to be considered when addressing non-medical drivers of health. We touched on that pretty heartily during our first session. As we get into our panel and the discussion with our three panelists, we're going to dig into this topic much more deeply. Third, the idea, while impact measurement can feel overwhelming, it is achievable with the right tools, data, collaborators, and that idea of sequencing, where to begin, how to get measurement going in the midterm, and then what to look at long term. So we want to make sure we don't scare you all away by what we're talking about, and really make sure that this does feel approachable. And then the final one, and perhaps the most geeky or nerdy, but this idea that measurement really is for everyone. And if we do our work right through the consortium, we will see that, because data-driven storytelling to inspire the heart and the brain is the way that we're going to make collective impact and move the needle on non-medical drivers of health. And the root for a lot of that does come from impact measurement and evaluation. So I'm going to share two quick slides from our prior session. I will make sure that someone from the team puts in the chat the link to both the recording and that first deck, if you're so inclined. But as you will see as we talk through our panel discussion today, there are multiple levels of impact measurement that vary in time and complexity. And part of the magic with getting it right is making sure that the time and the complexity are well aligned. Meaning you're not trying to ask too complicated questions too early on when you might have more limited data, or you're being a little too cautious later on where you could ask and look at bigger, more impactful things when more data is available to you. So it's a journey, right? Both complexity and time allow you to look at and measure different things. The second thing, and you'll hear this also from our panelists today, is there's a tremendous amount of intersectionality between the work that we do. And if we're really trying to move the needle on a particular sphere, a particular type or interconnected collection of non-medical drivers of health, it's not individual initiatives that live in their own work streams. It's looking at those interdependencies and the collective ability to rise that waterline. And so you'll begin to see through some of our discussion where some of those overlaps lie. And then the third piece, and this will also come through in our discussion, is there's not just one impact narrative to tell. And all of us have challenges with sustainability. All of us have challenges with making sure that community partners see the benefit in the work that we do. So what we'll touch on as well is a little bit of how that narrative changes around impact-driven storytelling and impact measurement, depending on who that stakeholder is and what they care about. So our today's panel, I was introduced as the moderator, so thank you for that. We have three fantastic panelists, Mike Dotson, Amy Hooten, and Tate Ringer. They will each have an opportunity to introduce themselves to you. They can do it much more elegantly than I can. So they'll spend a minute introducing themselves, introducing some information about their program, a little bit of history in terms of where they're at in their NMDOH journey. And then after each of the panelists does that, I have some questions that'll kick us off. And then, as both Jessica and Elaine said, we'll then open it up for question towards the end. If there's one thing or a handful of things on one slide to listen for as we go through our discussion, I really want you to listen to the differences, the similarities and differences based on the types of organizations who are sharing their stories with you today. By design, each of them is tackling non-medical drivers of health from a slightly different root organization. And because of that, there's some nuances in the approach, but there's also some keen similarities that you're going to see. Secondly, I really want you to listen for some similarities and differences on the types of data and the types of access to data, because that becomes very foundational in how we really are able to perform different types of measurement, obviously predicated on the type of data we have access to. And then the final piece I touched on briefly in that prior slide, but actively listen for how the panelists have modified and modulated the narrative based on some of the key constituents that they've been bringing alongside them on their journey. So 3 things to listen for, a brief overview on our panelists, a little bit of a preview around what we did in our prior session. So with that, I think all of you have a good foundation to jump into our conversation today. So with that, I'm going to stop sharing. And Mike, would you do the favor and get us kicked off and give us a little bit of a background on your programs, and your approach to non-medical drivers of health?
Certainly. I'm Mike Dotson. I'm the CEO at Access Health. We're a FQHC in Fort Bend County. So we're just southwest and west of the Houston area. We see roughly 20,000 or more unduplicated unique folks every year. We do about 70,000 medical visits. Our county is sort of a mix of urban and rural. We've got a lot of folks that live here. We've got a lot of folks that are moving here, and we've got a lot of land that will be developed. So I think, as the county continues to grow, the work that we do will be in tandem with that. The United Way did some analysis a few years back on the ALICE population, which is asset limited, income constrained, yet employed. And if you added those folks to 200% at or below federal poverty, that's roughly 30% of the of Fort Bend County. So we've got a lot of need where we work. About 6 clinics in Fort Bend and 1 in Waller County. We have been longtime partners with the Episcopal Health Foundation, and began our work in non-medical drivers of health probably 7 or 8 years ago with the community-centered health home project that was taking off as part of their initiative there. Currently, we have a really robust food RX program that we operate in all of our clinics, medical legal partnerships in all of our clinics, and we are an active participant in Greater Houston Health Connect HIE. We've worked with county government through a variety of endeavors associated with 1115 waiver. And I think most recently have joined a clinically integrated network, sort of an alliance of FQs in Texas that is the product of some work that TAC is doing, aimed at creating a collective to be able to kind of work and negotiate with payers on value-based care and things that are sort of coming down the pipeline. But that's where we are. I look forward to the discussion, and certainly welcome any questions or anything that anyone would have. So thanks very much for having me.
That's great. Wonderful. Amy Hooten, would you mind doing us the favor as well, introducing yourself and some of the activities that you've been up to? And Amy, you might be on mute. Let's do this. Let's have someone from our side, from a tech perspective, see what, if Amy's having some problems. And Tate, how about we go to you, and then we'll circle back to Amy.
Awesome. Hi, I'm Tate Ringer. I'm the Chief Strategy Officer with MetroCare. We are Dallas County's mental health and disability provider. We are, I know a lot of our colleagues, sister centers are on the call, but there may be some that don't know what that is. We are both an agent of the Dallas County, so we are a governmental agent and have a nonprofit tax status. So that gives us some opportunities and some challenges. I joined MetroCare in 2019, about 6 months before COVID. So as the strategy officer, just as I was developing out our strategy for the next 3 years, we changed our strategy when COVID hit. So the journey for understanding the non-medical drivers of health began before I came on board. I would say it was hastened with the advent of the CCBHC, the Certified Community Behavioral Health, of which we embarked on that journey, been watching it since it started, and then actively started planning and preparing for the application around 2017, 2018. And so, of course, as a CCBHC, that is all about encompassing the non-medical drivers of health as part of the mental health care. So that, to some degree, it's nice sometimes when you have both a funding mechanism as well as a structural mechanism to drive you to think deeper, more intentionally about data. But that was really just the beginning. And since then, I think over the last 4 years in particular, since in my role as strategy, I oversee both innovation and inter and intra agency collaboration and cross-pollination, both breaking down silos between our disability population and our mental health population. We've got about, we think now about 25% are duly diagnosed. And that's probably the ones that are actively seeking treatment. So we assume that that's more. So that goes into looking at the data and then also reading beyond it. Just to give you context for those who don't know, we serve about 50,000 patients, individual unique clients a year. We have about 1,300 clinical encounters on any given day. And of those, we have about 130 walk-ins on a daily basis in our mental health clinics. I've got to go back and recount our clinics because we have 9 freestanding clinics, but that number is getting a little bit difficult to describe because one of them is embedded within the key homeless shelter in Dallas, and it's only open to those people who are being served by that shelter. But we also have clinical operations within another food pantry and homeless services center, and that's open to the public. So counting our numbers of how many centers we have, that's really up to about 20 now when you start talking about satellite offices. And that'll be something I'll talk about later when we get into what our numbers are driving us towards. Anything else I need to include, Leslie?
Yep, Tate, that was wonderful. Thank you very much.
You bet.
Amy, I see you back on. Very good. Can you do us the favor as well and introduce yourself and the program that you oversee?
Yes, sorry for my technical difficulties. My name is Amy Hooten, and I'm the EMS chief here in Longview, Texas. And I also oversee the GLOW program, which is called Greater Longview Optimal Wellness, which for the fire department is a community health paramedic program. For our community, it is a TACHI collaborative, Texas Accountable Communities for Health Initiative. We're a new program, started our 501c3 in 2021, and have been seeing patients or identifying and navigating patients probably about 9 months. We're at 160 approximately 160 patients that we've seen. We identify our patients by 8 or more 911 our emergent calls in a year's time. And then once we identify those patients, we actively help them look at disparities and social determinants or non-medical drivers of health to see how we can navigate them, make sure they're meeting their PCP appointments. We have eight agencies in our collaborative. We have 2 hospitals in our community. We serve the city of Longview, but our partners in the Tachi Collaborative serve our greater Longview area and Gregg County. So community health is our health core is our mental health authority. We have 2 FQHCs, Wellness Point and Special Health Resources, 2 hospitals, Christus, Good Shepherd, and Longview Regional Medical Center. We also partner with United Way and let me see, the city of Longview and Gregg County. So I believe that makes up our 8 partners. And yeah, that we're new in this work and excited. We're seeing progress and positive change in our community.
Great. Amy, thank you much. Thank you very much for that. So I'm going to ask something of each of you, and whoever wants to jump in first, feel free. And the question is, given where you're at today with measuring the impact of the programs you just described, is the way you thought you would think about measuring impact similar or different today from when you started? And what are you using as those core kind of tent poles in the ground when you talk about the impact or the success of the programs that you're overseeing?
I'm happy to jump in here. I think, initially early on, we built a lot of the sort of the analytical kind of questioning piece of the non-medical drivers of health information into our electronic health record. So if somebody's getting admitted through registration online or any of the types of ways that you can enter the organization, we're asking a lot of questions. When we started our food insecurity piece of that, and our largest clinic, which does about 60% of our volume, of the patient base, about 40% were indicating that they were food insecure. So at this point, having the right referral partner for our food X or partners was a big piece. We wanted to be able to obviously do the right thing with our patients and sending them to a place that would meet their needs, and wanted to make sure that we had some accountability with our partners. But then thereafter, wanting to sort of indicate on the front end that what this may do to the partner's volume. And I would say our largest partner probably was up 2x year to year in us running our first iteration of our Food RX program. Of the 40% that were getting prescriptions, about 70% redeemed. So we had a fairly large number. We're very successful in continuing through that. We were able to sort of measure clinical measures at the individual and aggregate levels through our EMR. We have a bolt-on navigation platform that works and helps us grab some additional data and data points through that. I think for us, the biggest thing is just being patient and being able to sort of document or to analyze a direct relationship between what we're doing and health measures. And that, frankly, has not come, I think, as quick as we would have liked, but just sort of saying the course there and wanting to make sure that what we're doing, I think intuitively makes a lot of sense, but moreover, specifically aggregating the data and seeing some meaningful movement. I think we're still waiting to see that happen.
Okay. That's really good. And Mike, I'm going to hold on to something that you said after both Amy and Tate respond to this question as well, given the fact that where you're anchored and the access that you have to easy EHR data. So Tate, share your perspectives on my first question.
Amy, do you want to go next or did you want me to go?
Oh, it's fine. Go ahead.
Okay, so yeah, it was a multifaceted question. I think we had the opposite challenge, Mike, in that we had an existing EHR and switched in 2018. And so that switch, and then we highly customized an EHR that's used across the state by a number of different providers like ourselves. And so now we are kind of reaping the not the rewards, the repercussions of that customization when we went into that project. So now we're not able to pull some of the data that we would like in the same way that some of our sister centers are doing. So, and I think this speaks to the importance. You might be surprised how many times I talk about non-technical and non-data things when it comes into getting the buy-in across the organization. We had such a difficult experience that nobody really trusted IT. Nobody really trusted the data. We were pulling reports from different sources. So a lot of what we had to do in the beginning was to clean up and really work through and everyone really should do this with their EHR, is making sure, especially in larger organizations, is everybody pulling the same reports the same way? And are we reporting the exact same way? So our initial journey was really consolidating and re-looking and reframing some things and building out, changing some of the EHR components in order down the road. And we had to take a few steps back in order to make a huge leap forward. So you can do it either way. If you start out clean, then get some advice from some people who have done it before. Do what I, say, not what I did, so to speak. But it's also worth it to take that step back and really think about the data, the reporting. Because everybody thinks about, okay, how many clicks? How is this going to work? How is this EHR going to function? It's not typical that you think about, okay, what do I need the output to be down the road and how am I going to get that output? And having a data specialist think about that as part of that journey will make a difference on the ease down the road. So that may not be exactly the question you asked, but it might kind of inspired me.
No, it's good. It's those things that you don't think of until you've done it once.
Mm-hmm.
And there's the main narrative around what we're trying to accomplish with measurement and all the blockades. There's some blockades around data use agreements. There's some blockades around good habits with data. I know for a lot of the community-based organizations on the call, staff turnover is such a big deal. And so to your point, you might go through training once and say, yes, we now have everyone trained up on how to pull this data this way. And once you've done that, you go back and you realize it's a whole new group of people. And so it's that ongoing, hygiene and muscle memory that needs to live beyond a set of people. That needs to become almost that organizational competency around doing that, just given the amount of people turnover that we're constantly struggling with.
Yeah, and that's is as important as the analytics side itself.
I agree completely. Amy.
Well, we are just starting out on our data journey and currently not integrated with our partners. Our current data is pulled through our patient care records through EMS. And then we are, UT Tyler is working, Episcopal has funded them to help coordinate our data. So we are currently on that journey to get hospital data on these patients so that we can overlay that data with the EMS data. That's been a huge part of our how to de-identify it and get that data together to overlay so that you're seeing all the different components in our community of the interactions with the individuals. And so we're really beginning that data kind of journey and doing a lot of in-house documentation. Sometimes for us, even filling it out on a paper form and then transposing that into a spreadsheet type format. And so we're really at our beginning stages and have not found a way for our 8 partners to integrate our data, as we're all different agencies. So that's a huge hurdle. It took us 6 months to get a HIPAA agreement through all our legal teams that everyone was happy with, that we could get our patients to sign to allow us to share de-identified data. So it's definitely a challenge, but it can be done. It just takes some time and some perseverance, and definitely learning from folks who've done it before you is helpful. Our EHR is new here in the fire department. We got a new program in 2021, but again, we do have some access of the hospitals. They're able to log into our programs now, but as far as sharing and combining patient data, we don't have that capability. So.
That's Amy. Thank you for that. Mike, I want to go back to you for a moment. When you and I had our prep call yesterday, we spent a couple minutes talking about the Houston HIE and how having access to that has been something that's allowed for you to have a little bit more of that longitudinal look, such that if people that you were seeing through your support went through one type of maybe adjustment or modification of some of their behaviors, they didn't ping pong to somebody else, and you were able to see that longitudinal look of individuals that your whole community was trying to serve. Speak a little bit more about how you've seen the HIE work in a positive way for the work that you're trying to do. And then Jessica, as you're putting notes in the chat, I'm curious from the broader group, how many folks actually live in communities where HIE access is something that is available. And then Tate, I'll have you follow up after Mike. Dallas is in kind of an awkward spot where kind of, I want to say HIE light, but it's probably a little bit different than maybe the Houston experience for the type of information that flows through the HIE.
Mm-hmm.
Yeah, for us, it was, it was a long time coming. There'd been a lot of time and energy put into developing the HIE. We hit a tipping point with hospital systems coming on board, with community health centers coming on board. So I think now we've got so much coverage that, even at our local community hospital, which there are very few left in Houston area, we can have a lot more information on our patient, through our medical record. Our physicians and providers are using that, daily. So I think that, yeah, that's been a big win for us. I think it's absolutely, targeted directly, readmissions to emergency rooms and the things that were affecting, a lot of the people that we see. And, frankly, for our physicians, just to be able to communicate, about visits and things that have happened outside of our place, and if they've represented at other FQHCs, to be able to tie into all of that. And then so yeah, I mean, super helpful and really changed a lot of what we're doing. On the non-medical drivers of health side, there's a lot of collaboration happening in Houston, with folks wanting to share data and to create platforms and systems. And we participate in much of that as we can. And certainly, I think if we can get some of these platforms on the non-medical driver side that are able to communicate and able to share, then obviously we throw a much bigger net over what we need to do. So seeing progress in that front is got to be pretty optimistic for us. But specifically to your question on the HIE, has absolutely benefited everything we do in more ways than I can probably touch on here in this conversation.
Great.
I have a question for Mike.
Yeah.
Maybe it's worth it to how many people are on your HIE, and is it most everybody on the same system? Because I know a lot of Harris County has gone to one provider.
So a lot of folks on that one provider. We are not. So the interface that was built, I would just talk specifically about our experience, was pretty painless. I think we're with an EHR that they work with, and they were brought into the discussion. They being the HIE really early on when we made a decision about moving to a new EHR. And there was, a big part of us wanting to make sure that it was something that would integrate with them. So there in Houston, I think our biggest thing for us was, HCA coming on board. That happened probably about 2.5 years ago. And then our regional hospital. And I worked directly with the CEO there to get them on board as well. So I think from a tipping point, we catch most of the organizations that our folks are seeing. And we've not had any issue with our not Epic EHR working with the HIE. Yeah.
The EHR not to be named.
Right. Right. So for folks on the call, you can see the range in some of that foundational data that our panelists have to work with. Mike, on one hand, has this much more longitudinal look and can ask perhaps a slight different set of questions around role and impact, both transactionally and clinically, on some of the interventions that are NMOH inspired and how they're actually moving the needle on individuals and health within community. Amy, on the other hand, is working in a different way to be able to start asking those questions, knowing that the way she's going to be pulling that data is going to need to be different. And so the message to this group isn't to wait until you're in a situation like Mike's to begin. It's to be practical and figure out what types of questions you can address based on the types of data that you have access to. So, yep. So let me turn it back to you for a moment. With the data that you have access to, as you think about what you're trying to measure through GLOW, what are a couple of those key impact questions that your team is actively addressing?
Well, we're handling each case individually and then looking at the non-medical drivers for each individual and then trying to navigate them to one of our community nonprofit offerings, whether it be a food bank or whatever the case may be, and keeping data on which components in our community that individual resourced and what helped or made a difference in their outcomes. And mainly for the clients that we've seen so far, we're looking at food insecurities and then just resources for medications and making their PCP appointments, and just us circling around them and communicating about an individual's needs, obviously with their permission, and making sure they're reaching those touch points. We've seen a definite positive outcome for the individual and a better life outcome, and then also just a total healthier lifestyle. And then we've also seen decrease in the ED room usage and the 911 response, even in our non-transports that we were seeing in our community for those individuals. So definitely non-medical drivers are playing a key component. And again, we're collecting those things on an individual basis and then combining them manually here in the office. So I would just wanted to speak to your point earlier that if we wait for everything to be perfect before we start an initiative, we'll never move anywhere. So especially when you're collaborating with different corporations and hospitals and different agencies, and you're talking about HIPAA and different things, we all, whatever size community you're in, you need to make an impact for these individuals and for your community to be healthy. It drives not just an individual's health, but also your economic health in your community. So, whatever size community you're in or wherever you start, you can start somewhere and then build upon that. and hopefully we'll get an EHR here in Longview soon, and we can, that's exciting. So I'm going to learn from you guys, and then hopefully someday I'll have access to that here locally.
Yep.
Awesome.
Tate, let me go back to you for a moment. The types of things you're measuring, Amy had mentioned the fact, primary care appointments. That's something, it's countable measure. Mike mentioned closed loop referrals for some of the food RX, the ability to have that food, that food referral closed. So important measures related to non-medical drivers of health, but countable measures, things, whether it's a closed loop referral platform for SDOH or whether it's visit counts that you can pull. What are some of the things that you're actively measuring that kind of live between or are complementary to what Mike and Amy have mentioned?
I would say all of those, but some of them not as specifically. Like we're not seeing necessarily counting when they will do the closed loop referral, but not necessarily capturing how many times did they actually pick up their food, right?
Mhm.
So, and I would say we're also in between Amy and Mike in the sense that we have multiple collaborations that are capturing different sets of data. We have a veterans program in which it's a closed loop referral system. We had to create a special data aggregation system and hire a special data team in order to analyze and aggregate all of the de-identified data. So that took us 6 months just to build the FTP site and the process and train everybody in it. And that program's going on now 6 years in order to ensure that veterans get referral and access to all the services that they need. And so there's multiple sources of information that we're capturing that the state wants to know all along these lines. We have another initiative with the Dallas Police Department as a part of their focused deterrence program, which is a nationwide program, pretty innovative. And we partner with a navigating team that was created for this to improve employment. And it also offers support services to the most violent felons to get them out of their current job of crime and into new opportunities. And so we're measuring whether or not they're creating resumes. We're measuring whether or not they're going to interviews. We're measuring whether or not they're inviting their spouses. Are they accessing childcare? And then we have UT San Antonio is the one that's aggregating it for Dallas and for 3 other cities. That's a whole separate initiative. We are supplying our information and then other teams are aggregating that. And sometimes it works in the reverse. We're also working with a suburb that's a conglomeration of 4 different cities that we're co-locating in primarily what's a food pantry and financial assistance program. And right now it's a closed loop referral system because they're already getting their food pantry information, but we're looking at dental coverage, we're looking at transportation, and frankly, we know there's a need there, but are they even going to access mental health services? So some of that is we're challenging the questions that we're asking and the assumptions that we're making about what the needs are. Just because there's a gap doesn't necessarily mean there's a need. So we're starting to capture that, and we're capturing that in yet another system. So and then the last one is with our FQHC. We've spent 2 years integrating our data share agreement. We actually co-locate a social worker within the ER to actually support and feed those. There we're capturing, are they making their referral appointment? Do they have transportation to that appointment? So, and then we have the data share between us. And we absolutely could not have done that without some of the expertise of the data organization that we worked with. Leslie might be familiar with to help us with it.
Yeah, understood. So Jessica just put in the chat for folks on the call or who have questions that want to ask. We're going to open up to the floor in a minute. As I've heard the 3 of you speak, it seems like the way we've been putting data to work really falls into three different areas. One is around asking questions, is are the programs we're designing in doing what they intended to do? So, we built it to do X, and we're collecting measures to the best of our ability to say, are they doing X? Yes or no? And if yes, great. If no, how do we course correct? All of you touched on it to a certain degree. It's like, are we making things easier for people? And that could be our clinical teams, it could be our social workers, it could be our patients, their families. Like, if this mousetrap isn't getting less complicated by doing what we're doing, have we really moved the needle on much? So it seems like through both probably some of the qualitative information we get from patient and families themselves and other data we're looking at, with the data we have access to, we're trying to say, are we making the system either more efficient, a little bit more accessible, a little bit easier? And then the final categories is like, are we moving the needle on some outcomes that matter? That could be utilization outcomes, it could be person level outcomes, or something that's going to make the collective quote unquote system better, or that collective experience and healthy life, healthy community for that individual. So for Mike, Kate, and Amy, does that resonate? Is there another bucket there, or is that a reasonable way for our group to think about those three tranches of space for which impact measurement can live?
That was an excellent summary, Leslie. And we're all sitting here nodding our heads.
Yeah.
I couldn't really add much to it. I would say just specifically in the work that we do, initially, our physician group was very hesitant to ask questions when we did not have a resource to connect someone that had a need. So building partnerships and accountability and options, I think, had been some work that we had to get busy on to make sure that there was capacity for the questions that we were asking or wanting to ask. And then our role in some of these partnerships has been almost like a liaison type role. So in Food RX, we connected local food pantries with Houston Food Bank, which is probably the first or second largest food bank in the country, and just kind of got out of the way. We brokered the relationship and connected all of the dots on that front. And sort of now our role is just predominantly a liaison between the two. So that was just very different for the organization and delivering care the way we had delivered for so long. And yeah, those two things, I think in the beginning, when we wanted to ask all of these questions, our physician group was really adamant that, hey, if we're going to ask a question, we better have some type of a resource or a resolution or something that we could do for the patients.
Yep, that's a very good point.
Now, I would say we're the same. I'm sorry. I would say we're the same as connecting the dots basically in our community, and then letting people do what their expertise is really what. And if that didn't complete the needs of that individual, then circling back, reassessing their needs and seeing what other blanks we were having for them and what else we needed to plug them into, and just assessing and reassessing until we felt the individual felt they were stabilized and getting the resources that they were needed. Often people don't know what resources are available to them, and so just walking them through that option in a kind of a one-on-one basis is what we're doing, and it seems to be helping them connect. And then once their needs are supplied and they then we're kind of out of the system until they need us again. So
got it. Okay, so then I have a couple additional things that have popped into my head as we've been talking. For each of you, if there was one thing on your wish list, and that's either data, process, fill in the blank, what is that first thing that comes to mind?
For us, I think challenge is workflows. Changing the system. The system is we do what we do in all our jobs every day, and we do our normal things, whether it comes to healthcare, to a clinic, to EMS, and thinking out of the box and coming up with a different workflow or a different option, or even combining options together. That's always it's a challenge, and it takes time. For me, being in a new organization and looking at some of the folks that are in a longer standing organization, it gives me some hope, because some days are challenging to see that processes can change and we can find a middle ground. We just got to keep working at it and try. So that would be one of the things. If I could speed that up, that would be one of my things I would like to see.
All right. So Amy, it's workflow and speed. All right.
Yeah.
Tate, what about you?
Well, Amy went big. I mean, I was trying to think of like what's doable on my wish list. If I was going to go like, the sky's the limit, it would be two things: an integrated system that, but I think that's also the only way that's possible is if funders start to agree on what the reporting expectations are. I mean, whether it's state, federal, private, we have so many different measurements that we have to keep track of. It makes it so much more cumbersome for our staff. And so there's a whole nother topic about how to get buy-in with teams. But but if that was my grand wish list, it would be that we had some more consolidated outcomes and reporting requirements.
Very good. Mike.
Yeah, so I think for us, I mean, starting to warehouse all of this information and data, having a piece that would do more predictive, proactive type referral, I think would be major. We're asking a lot of questions now, and we see folks quite a few times a year, so we're asking these questions, quite often. So I think if we had some some substance and some really sort of powerful numbers, and to kind of go in and look at the communities we serve and make some predictive assumptions about what folks would need, and then maybe proactively just be connecting them through some type of tech tool or something like that, it makes a lot of sense. So I think from a wish list standpoint, that would probably be high up there for me.
Got it. Mike, thank you for that. I have one final question. Oh, Ray Jones, he provided a question came into the chat. And the question is, have you ever found that your intended evaluation criteria needed adjustments based on program implementation? Meaning you had planned here and you ended up maybe here. And how did you either course correct, or did you have to reset expectations based on what that early experience showed?
Oh, that's a good.
I don't think change expectations add to. I think we've had to add to and go, okay, man, that's a good point. We need to collect that data too, and we need to collect this too. And it just kind of expanded the program. Yep. And then when people ask questions, you go, oh, that's a good thing to be looking at. Let's look at that as well. And so expanding the foundation of where we started and expanding on it.
Yep, very good. I'm going to do this. A, Ray, thank you for that question. B, if there are other questions that come in the chat, we can follow up with our panelists to be able to provide some of the insights. Before I have to turn into a pumpkin and hop to the next call because we're back to back, I do want to thank Mike, Tate, and Amy for their perspectives. I know them and I learn every time I'm with all of you. So thank you very much. Please provide any additional thoughts, perspectives in the chat. Jessica, I think you're going to wrap things up. And so I will pop off at the moment. But to everyone, thank you very, very much.
Thank you, Leslie. And Jessica, we can't hear you if you're talking, or I can't.
Sorry about that. Sorry about that. There I was chatting away. Thank you for telling me. Thanks everybody for joining. Great conversation. I really enjoyed it a lot. I just want to remind everybody on the group, if you're still here, to please complete the program index. You might want to bookmark this particular QR code or the link, which is right here, and fill in your programs when you can. It'll be, I think, a useful tool for everybody. We're gonna let everybody leave now. I know that a lot of you are planning on going over to the next session. The next session has another link that you have probably signed up for. So I'll say thanks again to our speakers, Tate and Mike and Amy, and of course, Leslie, our fantastic moderator. Thanks everybody for joining, and seeing you in the next room. Have a great rest of your day, everybody. Thanks so much. Okay, Tate, or you need the link to the next session. Let me see what I can do for you. Do I have the link? You know what? For some reason, these things are not coming in. I do have it. If you just give me one hot second.
In case somebody else wanted one too, if they wanted to, they loved it and they want more.
Yeah, well, I think something like 85% of the people are coming to these, right? Oh, so Angie's got, so we've got a registration link for you.
Okay.
You'll just let me get the registration link, and you can use this and register, and you'll get straight in.
Awesome.
Okay, so
Are you putting it in the chat, or?
I'm putting in the
Okay.
chat right this hot second. Here we go. All right. Yeah. Thank you, you guys. It's so hard to do this when people don't have their cameras up or are asking questions. I don't want you to feel bad. We didn't have any questions in any of the other sessions. But this was really a fantastic conversation. I think you're doing really interesting stuff. So thank you so much.
Hopefully it inspires some people to take another step further, or maybe a first step, or that they're in good company if they're struggling.
We're all there.
Yeah.
Okay, great. Well, we'll see
Awesome.
you.
Thanks,
Bye-bye.
Jessica.
Bye-bye.
Bye-bye. Nice to meet you, Amy.
Nice to meet you.